Uh, well, uh, the lecture, the title of this lecture is How to Improve Cryoablation PV Isolation Safety. Everybody remembers the results of a study Ice and Fire, comparing the cryoablation and RF ablation, but I think that's more representative for the real world. It's results of study I'm showing you. That's a publication from this year. It's cryoablation versus radiofrequency ablation according to registry, European registry and Swedish registry. I will not come in detail, but basically what they showed, it's over 4,000 patients who underwent first AF ablation, both cryo and RF, and what was concluded that the cryoablation was associated with lower reablation rates and shorter procedure time observed with as compared to RF. So this shows the advantage of cryoablation, and despite my great respect what we have seen yesterday, I really do believe that that maybe these results indicate that maybe cryoablation have to at least comparable or even better future, especially in respect that complication rate was quite similar. So we have the same complication, but shorter procedure and lower reablation rate, which is essential, I think. This is table from the same study showing the complication before discharge. And I will not come for all these details because there are too many of them, but look, this cardiovascular, and we see that's RF ablation, it's cryoablation. I will not comment it, but you see there is a difference. But I would like to concentrate on something which is maybe most dangerous. So it's esophageal fistula or perforation. This is one which we are afraid from, and I would discuss how to avoid it. And secondly, the phrenic nerve damage, which in contrast to this cardiovascular, was observed much more often with cryo than in radiofrequency. So what I'm going to say, first of all, I think that cryoablation will dominate soon as a method of first ablation of paroxysmal and perhaps persistent atrial fibrillation. And secondly, there are some problems associated also with this procedure. And therefore, I would like to show you some studies on safety on this. And one issue I mentioned is injury of esophagus. And this is study analyzing luminal esophageal temperature, which predicts esophageal lesion after second-generation cryoablation pulmonary vein isolation. We have two tables. Those rumps are with the lesions and the circles and no lesion, and we see that's the drop in temperature. We see that those cases with lesion were associated with significantly lower temperature measure in luminal esophageal probe. So lower temperature, the risk of some damage in esophagus, of course, is higher. And there are some analyses according to the veins which underwent ablation. So we see right superior pulmonary vein that was associated this ablation with most of damages. So we have from one hand the value of temperature drop and the location of ablation, which are associated with the risk of esophageal lesions. The same group, this group from Frankfurt, made a further prospective study after this evaluation we've seen. They found that it's somehow cutoff of the risk is 12 degree. So they placed probe like this. We see it. There are three. The temperature probe in esophagus. By the way, they measure distance from in this areole projection from balloon, cryo balloon, to the esophageal probe, to the esophagus. You see that's like 6 millimeters, so it's nothing. So it's very closed, and they found that it's safe. It's when it is not lower than 12 degree, and in the case of dropped temperature, under this value, they stopped procedure. They also used mean or a little bit even higher level in other groups, but I will not come that far in details. Okay, I thought it might be from EP, but it's not. You see, we had this in the whole patient group. We had when they used its 12 degree cutoff, they had 2 complications. And another group, they used this 15 cutoff. It was only 1 complication for the analyzed group. But when they did not, intervene, just observe what's happening with patient, allowing drop of temperature below those values, the number of lesions was much more higher. So it means that this kind of assessment and intervention by means of stopping procedure really works. There are some examples because they performed endoscopic evaluation after every procedure, and you see that's one of the most spectacular, I think. It's submuscular hematoma which drained into esophageal lumen shown during endoscopy. And others also, but repeat esophagoscopy demonstrate a healing of all lesions. So in this case, they were not the most dangerous complication. So it is one way to avoid the problem with ulceration of esophagus. Just control temperature. Another study which I want to discuss with you, it's the phrenic nerve, or another issue, it's phrenic nerve palsy. There is study from 12, it's 6 years old, showing predictors and prevention of phrenic nerve palsy. It's a study from Switzerland, from Christian Sticheling. He was our guest 2 or 3 years ago. We see here the right atrium and the left atrium, and there are places where they stimulated inducing the palsy of phrenic nerve. You see that's how close and its diameters the phrenic nerve is from this place, and there is right superior pulmonary vein, which is very, very close proximity. It's again the place which is most dangerous. Both for ulceration and also for phrenic nerve. And they analyzed, you see there are groups. We have the no phrenic nerve palsy, this one, and phrenic nerve palsy, and they looked right superior pulmonary at temperature during light superior pulmonary vein isolation. Was it any difference in this temperature in those who had palsy or those who had not palsy? So you see, when the temperature went down to minus 55, as measured in a cryo balloon, They had those injury of phrenic nerve when the temperature was like 44 plus minus 8. That was no problem of this gait. What they also analyzed how fast this temperature go down, and what happens after 20 and 30 seconds and 40 after. You see when the drop of temperature was faster, like after 20 seconds, it is 33 degree already. Then it's the warning signal that itself may indicate the phrenic nerve palsy. After half a minute, like here, you have respectively 44 in the group with phrenic nerve palsy versus 28 when not complication observed. So temperature certainly plays a role. But not only this, what they another study also published 2 years ago, also position of catheter. This is something strange. I think that for me it was very interesting. You know, it's AP projection, and they look on the border of atrium, seen here, the heart, and the respect of balloon. So in this projection, if it's a situation like this, I will again. There are some details behind, but there are at least 3 possibilities. One is that cryoballoon is in the shape of heart. Second, that 1/3 is outside of the shape of the heart, and here the third situation, and then when this AP projection is more than 1/3 on the middle and down, the part of balloon is outside the shape of the heart. It indicates a risk of the injury of phrenic nerve, and analysis of different factors influencing the presence of complication. They found that number 1 is diameters of right superior pulmonary vein, and secondly, the third position I just mentioned. So that there are only 2 predictors of injury, and it's something which maybe it's worth to have in mind. Additional method of monitoring the function of the phrenic nerve. We have here. It's what usually do. It's pacing the phrenic nerve and place hand on the patient abdomen. That's what we usually do. That the very first sign of decrease or loss of diaphragmatic contraction, we are advised to immediately stop the ablation. But there is also another, I would say, more objective method. The use surface ECG leads and place this recordings over the diaphragm, and immediately stop ablation if there is reduction is so-called compound motor action potential, which I will show you. Now there is electrical signal registrators from diaphragmatic movement, so compound motor action potential, CMAP, which look like so. This is the recording, and this baseline CMAP, and after ablation, when the amplitude goes down during freeze, and we have the phrenic nerve palsy here when the amplitude is hardly visible here, the signals even, and then recovery after stopping ablation. So it's more or less how it looks. There is description how electrodes should be placed to record signal like this mentioned here. So the right arm lead should be placed 5 centimeters above the CPowerNet process, and left arm lead should be placed 16 centimeters away along the costal margin. So we have those two electrodes, which are, I would say, displaced from usual place of left and right arm, and the same here on the photograph. So this is the way how we can objectively measure this function of phrenic nerve, and we found there is another study from USA. From 15, they use this method to see phrenic nerve injury and association of changes in the signal I showed you a moment ago with behavior of the CMAP. And we see then when amplitude is diminished, it's lower, 33% from the initial value. It indicates the risk of injury of nerve. So that should be in this moment, at least at this moment, the application of energy should be stopped. It's what they recommend. Another way to improve safety of ablation with cryoballoon, it's too short application. There is a publication from Munich group from Professor Ellen Hoffman. They compared two protocols with 240 second and 180 repeated application of cryo energy, showing like here, then an outcome after 24 months. There is no difference, showing that it's reasonable to shorten application time to 180 milliseconds instead of the longer typical 240. And another study, ICE-T trial, recently published, which made analyzed two groups, 50 patients each. One was normal application 240 seconds with bonus freeze. And so it's typical arm, but the second one, if time to isolation was shorter than 75 seconds, it was no bonus application, so they stayed with the initial first one. And again, results which are quite similar to those I showed you a moment ago. So when the isolation is relatively early, then you can skip this bonus application, what they advocate. This is a slide from Ice and Fire, which everybody knows, and which it shows that even the advantage of cryoablation in the respect of cryoablation time was demonstrated, but fluoroscopic time with RF application was longer when compared to with cryo application was longer than with RF. It's clear because we don't have any. Sorry, no, it's not this. I'm just waiting for the phone from EP Lab. Therefore, this telephone was with me. So total fluoroscopy time in the cryoablation group was in this great study longer, which reflects the fact that we use much more X-ray using this technique and compared to RF, which is of course a problem. And There is one Greek study in contrast showing, there are different EP procedures here listed and sometimes, and I will not come to details, only conclude by saying that the cardiac ablation procedure performed in modern laboratory do not impose high radiation hazard to the operator. So it's good news, based on the observation of some different, electrophysiology procedure. But from the other hand, we have to realize that, our head, and it's it's not covered during procedure. And there is one study, there are more studies, but this one especially, I would say, gives some warnings, which reports on brain and neck tumors among physicians performing interventional procedures. Basically, they collected list of 31 cases of physicians with diagnosed brain or neck tumors. They were among them 23 interventional cardiologists, 2 electrophysiologists, and 6 interventional radiologists. They were physicians working for years. And in those group, in 26 cases, they were data available, the site of brain involved, I mean site where the tumor was diagnosed. So this malignancy was left-sided in 85%. So exposure for radiation is usually from the left side. And of course, there is no prospective study. There is kind of list of what was collected by this investigator over the years, but the 85%, it's rather striking. And one of the way how to avoid this radiation of head to our brain, which is important, by the way, but it's not covered in anyhow during our procedure, was this kind of protection cabin, which was involved already like 20 years ago, and evaluated in Belgium and France. And there is complicated table showing results of this. But if you look at this column, which goes dosage of microcephaly in face and waist, in those, I would say, patient with cabin, which is here, and those without cabin, or how we do it normally every day, you see that's exposure for face without any further analysis. You can see there is many times lower here when compared to the regular way. While waist, it's very similar. So it shows that this cabin was, in this case, very effective, at least in protection of exposure to face and head and brain, and what was said a moment ago. So therefore, we will show today you a case with cryoablation done in the cabin like this. Which I think it's part of the answer for the problem I mentioned, I know that many of you met also this cabin, and it's for many procedure it's not very useful. But I think that for a cryoablation, and it may be used with success, and I think that. We'll show this procedure today using such a cabin, and I think that from the reason I mentioned a moment ago, it was to be recommended. Thank you very much.